Great. Thank you so much, Elisa, for the wonderful talk you gave in the last segment on the central nervous system. And this segment, we're going to talk about the peripheral nervous system. So I'm super excited to see this. I know you have lots of results in humans as well as in animals. So why don't we just get started?
So obviously outside our brain, there's another world, just in case. I know neuroscientists sometimes are very much into the brain. Um, so it's the rest of the nervous system, right? So it obviously radiates out of the spinal cord and it controls a lot of our organs, our senses, and unfortunately also is responsible for some pain sensation that I'm going to end with. And there's a lot of treatment that can be done. And actually, ultrasound is no stranger to periphery either. Some of the, as we know, some of the papers, several years, several decades back to the Fry brothers, and a lot of effects have been reported that you can control neural activity in specific tissues and organs in various different species. And also it could have inhibitory and excitatory effects. Mainly inhibitory is what people have found with FAS, and reversible and safe overall. So we got started with that through some basically neuroscientists that were interested in the nerves. Ellen Lumpkin is now at Berkeley, and she enlightened us many times because we had no clue even where some of the nerves are in mice. The good news is that we used actually ultrasound imaging to locate nerves, and that's actually used a lot in the clinic especially for anesthesia induction. So typically for anything orthopedic, you will want the nerve to be anesthetized, and they use ultrasound to guide the needle and find the nerve. So we became experts in nerve imaging. And it's very important, by the way, to know where you're targeting, even more than the brain, I feel. So hopefully I can convince you of that. So we were stimulating the sciatic nerve, which is a mixed nerve. That means it actually codes for both motor and sensation. And we were getting responses in the rodent as a result of stimulating the brain, the nerve. And then we wanted to also inhibit. So the way we would do it, we would put an electrode proximally, and then have EMG recording distally, and then also have ultrasound interfering with the electrical stimulation. I'm going to show you also results that we have also in humans of that. So first, we find the nerve by the ultrasound image, and then we also find it by twitching. So we like I showed you in the previous example, we also elicited twitching with ultrasound, and we knew that we were on the nerve at the same time as imaging that. And then we will use electrical stimulation to induce it, and then try to inhibit that with focused ultrasound. So what we found is that the PRF is very important here. So you can stimulate if you go below 10 hertz, and you can inhibit in this case if you go above 10 hertz. And the caveat of that is that you also induce a temperature rise.
Wait. So can you back up a moment? Because I'm not sure how to interpret this plot to say.
Oh, of course.
Yeah.
In this case, it's very subtle, but we do. So in this case, it's a percent latency before focused ultrasound. So we were able to maintain the same latency when you were inducing focused ultrasound itself. So the inhibition of the electrical stimulation doesn't necessarily happen with every PRF or pulse repetition frequency that you get with focused ultrasound. You can actually enhance the electrical stimulation if you use a PRF lower than 10 hertz. So we call this excitation, although it wasn't necessarily significant, but it wasn't inhibiting. And then as you were having a temperature rise that was significant here on the order of 5 degrees C, you actually were getting significant change in the latency and a drop in the latency basically as an inhibitory effect. And the amplitude itself. The amplitude was actually even more significantly.
So you're causing them to twitch with the electrical stimulation throughout, and then you're looking at the latency when you apply ultrasound, and you see that if the latency stays the same, then you call it excitatory, and if the
Yes.
latency decreases, you call it. But so I'm confused here because usually when things happen faster and has a lower latency, is that not stimulatory? Why is that inhibitory?
But so the idea was that we're not inhibiting, so maybe we should say no effect. You're right. Instead of exciting, we can say no effect.
Okay.
It was we could see. I mean, I'm not showing it here. It was not significant, but in some cases, you could see that it was stimulatory, but not in all cases. So it wasn't as consistent as the inhibitory aspect. So no effect / excitation, we can say that. That's actually a good point.
Okay, but why does decreasing the latency, is that inhibitory or it's stimulatory?
In this case, we were actually. This is a good question. I think this is an inhibition based on the amplitude, and then we will see what happened. Excuse me, the latency as a result of the amplitude decrease, and we will call this the inhibition zone based on the amplitude decrease. But in the latency aspect, maybe that wasn't exactly, as an inhibitory effect.
I see. So they had a lower amplitude, but it happened faster.
Yes.
Yeah. Okay. Interesting.
I know. We call it, I mean, you can call it modulation to be sure, but because of the amplitude drop, we decided to call it inhibitory.
I see.
And it wasn't complete, by the way. It wasn't a complete elimination of the electrical stimulation. It was just drop. And then how does this happen? So because we don't have this skull and we don't create as much noise as I showed you in the displacement images in the brain, we actually trust the acoustic radiation force effect much more. This is what I'm showing you during the stimulation is in red, and then we stop the ultrasound and the nerve basically rebounds back to its original location. If we increase the pressure significantly, we can also see a cavitation map here. But more recently, and unfortunately, I don't have time to show you that, we've seen that stimulation with EMG recordings happens with displacements only and without any cavitation change. So this is something that Erica,
Okay, so let's back up a moment. So you're seeing cavitation even in the absence of microbubbles?
Yes, spontaneous cavitation. It can happen from high pressures. Oh, I forgot to say, these are higher pressures than in the brain.
What are the pressures you're using here?
The pressure we use is up to 20 megapascals.
Oh, wow. That is very, very high. And so your mechanical index is going to be very high as well.
Very high.
And you have to go that high in order to have an effect?
In our hands, yes. With a single pulse, you can induce, induce an effect right away. But you have to go to that level. You have to pinch the nerve, like literally with the ultrasound beam. Anyway, so that's why cavitation, we wanted to measure cavitation in this extreme cases. I think this is above 20, going up to 25, 30, to see the effect. We wanted to measure cavitation when we have it, right? So this was a positive control. But we have found lately, and this is something that Erica McCune is actually going to report at the FUN conference this summer that Kim, you're organizing, that cavitation, when we get the twitches, when we get the actual stimulation in the nerve, is not occurring. The displacement, however, as I'm going to show you in this later at the end, does correlate with stimulation and even pain sensation. Reduction in pain sensation. Okay, so, and then of course, temperature. In this case, because it's a very short-lived 5 millisecond pulse, very short-lived, but high pressure, nevertheless. We do get some temperature rise, but much less than what we have in the brain. Much, much less. Like, you can call it the temperature effect. I don't know. I don't want to say the temperature is out of the, out of the equation here, but it's definitely under a degree C. And more recently, Aramis Kamimura has actually been able to do this thermal strain imaging, where you can, as a result of temperature increase, you can measure the underlying relaxation of the tissue. Now, this is not in association with what I'm going to show you, the modulation aspect. This is something that he showed in a separate paper published a couple of years ago. And we found that we don't have the relaxation as a result of these temperature measurements. At least it's not within our sensitivity if it happens. All right, so we only go with the displacement because this is what we can measure, and we use it for both targeting and monitoring. And we also use functional ultrasound that I introduced earlier. In this case, we use higher frequency for imaging, 40 megahertz, and we have even better resolution than what I showed you in the CNS modulation. And so we image the mouse after craniotomy with thousands of frames a second, and we're getting a cerebral blood volume image at the same time as we are modulating the nerve. This is work done by Stephen Lee, who graduated last year in my group, and you can see now a three-dimensional raster scanning of the entire mouse brain, the cortex and the subcortical regions. And then we were doing this during electrical stimulation, and we can see that contralaterally, but also ipsilaterally. So electrical stimulation of the, in this case, the right paw, you can see the contralateral left hemisphere lighting up first with the, in this case, the change in the cerebral blood flow being both positive, but both positive and negative, but also really also transferring to the other hemisphere at a later time. So that's electrical. That's all electrical and just imaging the actual brain. And we also did whisker activation similar to Emily Masset's seminal paper.
I'm sorry, Elisa, could you go back? So this is, what is the lower picture here? You say delta F over F, this is a fluorescence?
No, it's not a fluorescence. No. This is a cerebral blood flow relative change to the baseline.
Oh, so F here is flow. Okay. Yeah.
Yeah, I'm sorry.
Yeah.
No fluorescence at all. This is all not, no probes, no bubbles. This is just blood flow changing as a result of.
And where were you sonicating?
We're not sonicating here. This is just electrical stimulation of the hind paw of the animal.
Yeah. Okay.
Yeah, and then we were picking up this electrical stimulation in the brain. We're just testing basically functional ultrasound as a result of peripheral stimulation without focused ultrasound. Oh, I have during focused ultrasound. This is wrong. I'm so sorry. It's not during focus. It's during electrical stimulation. I'm sorry. This is during fast modulation.
Okay.
So so Stephen basically did exactly the same imaging, and you can see all these arterioles here in the cortex, large arteries. And obviously, this is the somatosensory region and some subcortical region of the mouse brain. So during focused ultrasound, relative to what I showed you in the previous slide, much more subdued flow change compared to electrical, but nevertheless, both some cortical and also some subcortical regions here are lighting up. After the focused ultrasound is switched off in the peripheral nerve, we still have lingering flow change in the contralateral hemisphere. We don't know why, but this is something that we consistently getting. The brain doesn't switch off. I think it's still processing what happened to the nerve as a result of the focused ultrasound. Now, we're also thinking maybe there was also a pain sensation that's lingering. We don't know, but we definitely, this is, the whole story is not only during. That's basically what we found out from the periphery.
And in that one, I got confused as to which side is which, but it doesn't really matter. This is the hemisphere is contralateral to the limb that was sonicated.
Yeah, so I'm showing you the left hemisphere lighting up here.
Yeah.
Because we stimulated the right sciatic nerve. Sciatic.
Yeah. Interesting.
And this is an example of the transducer. I mean, you can always make out the imager here. We push the imager down because obviously the depth of that 40 megahertz ultrasound array, it's very, very, very shallow. So we had that here at the same time as imaging the brain, functional ultrasound. So this is by looking, we were looking also because we were thinking of pain, the C fibers are the ones that are activated when you have, because of the nociceptors that they have, so that the sensing the pain in that nerve, in the sciatic nerve. And also we had other studies that were guiding us in fMRI that revealed activation of the somatosensory cortex, the thalamus, and the anterior cingulate area. And then we looked at electrical versus, so electrical stimulation, and then we will have the electrode here in the mouse paw, and then we were trying to inhibit that with focused ultrasound, and then measure the flow on the brain. And so what I'm showing you here is contralaterally in the hemisphere. The stimulus is in orange rectangle, so it will be electrical only in the top one, and then electrical with electrical stimulation only was the flow was increasing in the contralateral hemisphere, and then it was be switched off, and then eventually go back to normal, to the baseline. But with focused ultrasound, we were able to suppress that electrical stimulation. At least we could find that it was very similar to what happened in the ipsilateral, which was basically almost null. So very, very small change in the percent cerebral blood volume change here, but as a result of electrical, but that could be suppressed with focused ultrasound. These are some of the examples of the images that we got. So this is with electrical, this region here, cortical region mainly, in the somatosensory, and then pretty much we couldn't detect any cerebral blood volume change as a result when the ultrasound will be on the nerve. And it's very important to know that we guided with displacement and we were on the nerve. If we didn't have the nerve in the focus, we will not be able to see that suppression. So if we're in the muscle or if we're out, the skin, we won't be able to get that. Some of the work that we did that got published last year with Ellen Lumpkin's group, who's in somatosensory biology of peripheral nerves, is see which kind of fibers in this axon of the nerve that we were targeting were getting activated. Pretty much all the fibers. I mentioned the nociceptors, but also we have other fibers such as A delta and A beta that process motor response. And we could see spiking activity across during ultrasound. And this is with a red dot ultrasound is on, and it will elicit the spiking activity on the ex vivo preparation. So this is ex vivo. So she teases out each one of these nerves in that nerve bundle. It was incredible what she has put together, and you can basically measure the action potential in every one of these fibers. And this is the A delta fiber here, and we can also see the conduction velocity. By the conduction velocity, you can separate basically the different fibers. So this is a C fiber that activates later. And then, what mechanism? So we have the piezo2 here channel that could potentially get activated as a result of ultrasound. Ellen at the time had a mouse line. There were knockouts of piezo2. Long story short, to tell you that piezo2 is involved, but it's not the whole story. So we did get a higher latency when we were trying to stimulate the piezo2 knockouts versus the controls, but the piezo2 knockouts were getting activated. So that means that piezo2 is, when it is compromised, it does actually prolong the latency, but it doesn't eliminate the focused ultrasound modulation. And we also did a mechanical actuator comparison versus focused ultrasound, and it was very similar. And obviously, as expected, the focused ultrasound has a mechanical component that gets, and the nerve has a mechanical component, and piezo2 is obviously a mechano sensation channel. And so all that was checked as a mechanotransduction mechanism. And the last thing I want to share with you is what we do in humans. We've been doing this over the past 5 years. We target the nerve very similar to what we did with the mice. We have a focused ultrasound transducer, concentric with an imaging probe. We use lower pressures in humans. We don't want to cause any damage at all. We use go down to 2 megapascals, and initially we thought we weren't going to see anything, any effect. It turns out we do. We have to target the nerve. This is showing you some displacement during the actual sonication. And we use the EEG, as I'm going to show you, to measure the sensation of pain or of suppression thereof. So this is some of the work that, again, Stephen Lee and Hermes Kamimura put together with a robotic arm that we started on the median nerve that basically is responsible for moving your 3 fingers. It runs all along our arm here. We were finding that nerve, and then we were seeing the displacement. You can see some shear wave propagating out of the source. So we're not sure, but the shear wave dies very fast. Initially, we thought, oh, the shear wave is going to be guided down the nerve and activate. And unfortunately, it has a very high attenuation, at least in what we're seeing. But we know we have the highest intensity at where we want it, which is basically on the median nerve. And we could see, we will put some EMG electrodes, and I had that also. I was a subject at the same time as almost everybody in the team. And you could feel some tingling from the ultrasound as a result of potentially, targeting the nerve, but no motor twitch. So that's something that across the board, I think we found that ultrasound does not induce a motor twitch that we see in rodents. And there was some picked up motor response, but it wasn't with focused ultrasound. But with focused ultrasound only, nothing. But maybe enhancing the electrical, but it wasn't really significant or anything. Definitely what we found with sensory response, where we put the electrode here on the EEG around the somatosensory cortex, we could see that we had a decrease in the amplitude here, also not significant, but that was the first measurement that we actually did in humans. All right, Stephen actually made a thermal pain device that you can press on the palm of the subject, and it runs hot water through it and gradually increases the temperature of the hot water being pumped through this thermofoil here, and with a Peltier device. And we're able to see the temperature on the skin, the actual thermal trigger. So as it was increasing the temperature from 28, I guess, what we measured on the skin, to 35. And then we would ask the subject to see, how they were feeling with the thermal instilled pain, and then with the ultrasound on. And then we compare with the ultrasound on and with the ultrasound off. There were randomized trials, so the subject was completely blinded to whether the ultrasound was on or off, and then randomized. So sometimes we send sham pulses, sometimes the ultrasound will be on. And what we found was that at the same time as measuring the displacement on the nerve that we were inducing every time with the ultrasound, we found a suppression, very modest, but a suppression nevertheless, of about half a rating, so half a pain sensation rating on the average. But it wasn't with every time we would have focused ultrasound on the nerve. It had to do with the actual displacement amplitude, and it wasn't a high displacement amplitude. So it wasn't like the higher displacement that the more the pain was suppressed. It had to be some type of intermediate displacement on the order of 28 to 60 microns that we could measure to get the pain sensation that was reported by the subject that they could get after the ultrasound. They would tell us, I feel less of the pain from the thermal stimulator than before. And that's basically what we found with displacement itself. So very subjective, of course, because as we know, like people have different pain thresholds, and sometimes it's also perception of the pain. So that's when we switched to the EEG.
Wait. Could we just so what you have is your subjects where you're inducing pain. You've also got the ultrasound and you're trying to modulate that pain. And you have a rating here as to what their pain score is. And so this is the change versus sham versus fuss. And you've split them into 3 different groups. Now, I'm a little unsure because some in cluster 3 seem like they have the same behavior as in cluster 2. So why did you separate out clusters 2 and 3?
We separated them. Basically, we did a K-means clustering, and we found that the change in the ratings was actually had a peak around cluster 2. So that's how we identified cluster 2. And then we looked within all the different clusters that were coming out of cluster 2. So either before with a low displacement or a higher displacements. And then we looked whether there was any pain rating change. So so we were guided by where we had the largest change in the rating as a result of the clustering.
Okay.
Yeah.
All right. It's interesting. Yeah.
Yeah, we don't really understand it because we thought the higher the displacement, the higher the pressure, the more you modulate. But the data told us a different story. Of course, there's something there here too, but it wasn't significant. And then we switched to EEG, and we partnered with we collaborated basically with a Paul Scheider's group here at Columbia that does EEG and fMRI for in psychiatric disorders actually. So they guided us through the different processing that we need to do, and we got the 64 electrode EEG biosemi cap that's worn now by all the subjects. And we were trying to basically see whether the pain rating level with the suppression of the EEG signal was actually could be actually detected. So again, the same stimulation close to the wrist of the subject, and then we will have the focused ultrasound here, more upstream. Again, the median nerve with the imaging transducer. And then we could see that we were getting, when we were on the target, this is on target up here, on target group, we were able to see a suppression of the somatosensory cortex EEG potential as a result of the ultrasound around the somatosensory region. And then when we would stimulate the nerve, we would stimulate but outside the nerve region, we call this the off-target group, we will have a very similar EEG trace compared to the sham. So this is all randomized, by the way. We found that when we don't randomize, there's a cumulative effect that confounds some of these aspects that I'm showing you here, sham versus focused ultrasound. So the randomization of this pulses was very important here. And then, of course, going to the clinic, we're looking to measure pain suppression, and these are after incision. We partnered with Chris Winfrey, who is a neurosurgeon here, who tries to basically remove some of the nerves, so some of the regions that are causing nerve problems. So, and in this case, he thought that we would trigger where his incision was made to cause the pain. And then, so there's a trigger point after in these patients. And then we will upstream again, put the transducer. This is actually their calf now. And so we were stimulating their pain with a mechanical stimulator close to the incision, and then we try to suppress that pain sensation. And then we found that, again, off target, on target, so this is the nerve here, versus off target. So we were stimulating here when the nerve was actually off to the left by 5 millimeters. And we found that, again, the displacement on the nerve with focused ultrasound when we were on target versus off target was changing. So we could actually measure that. And then when we asked again the subjects, there was no EEG here. This is some of our pilot studies, and we now switching to EEG for these patients. We found that when we were off target, we didn't see any difference in the ratings, and also on target, also no difference. But when we compared sham versus focused ultrasound, we could see that a borderline significance here with a few subjects. We could see that we could suppress some of the sensation from mechanical stimulation of the incisions. This is something that also verbally, after a few days, the patient will come back and say that their pain was alleviated, and that lasted over time. And again, for all the ratings across the, I think we did about 10 subjects here. Overall, we had a modest significance here, but nevertheless, a suppression of that pain.
And so in that upper plot, is it different from the sham?
Yeah, because the sham here was not found significant. Yeah. Yeah.
Okay. Okay.
Yeah. I mean, it is close, but yeah. So you're right. I mean, there was some sham as well that could potentially have significance, but overall, for these subjects, at least, we didn't see it. But the main thing is also when we were right on the nerve, it will make a difference. If we were not, we were actually could increase the pain if we were not on the nerve. So it's very important to target the nerve properly.
Yeah, very interesting. Yeah.
So that's my conclusion slide. A lot of different conclusions. So for CNS, with a higher pressure, higher frequency, I should add here, focused ultrasound, we could elicit responses at higher success rates compared to sham. We found that we can modulate neural activity in neuron brains for motor and somatosensory, but also some cardiorespiratory effects. We are trying to visualize with functional ultrasound the blood flow in the brain during focused ultrasound modulation, but also before and after. We have unveiled some thermal potentially mechanism through the temperature elevation and some displacements that are induced during the modulation and without significant auditory effects. And with blood-brain barrier opening alone, so no drug delivered, we could see working memory and motor response slightly, but nevertheless improved in Alzheimer's mice, wild-type mice, non-human primates, and with the some of the Alzheimer's subjects with associated amyloid and tau reduction. In this case, will be also in the mice for the tau reduction. I didn't show the last part. We skipped that. So, but that's published where we can actually also modulate fear in some of the genetics, which is a non-invasive optogenetics approach that we published last year. And on the PNS side, we could stimulate and inhibit peripheral nerve action potentials. The EEG showed both motor and mainly sensory modulation during focused ultrasound. Through the ex vivo preparation, we were seeing that pretty much all fibers in the nerve bundle were being activated. And the piezo2 channel had a role, but it wasn't the unique channel that was driving that modulation in the nerve. And lastly, in humans, we found that nerve displacement on the order of 30 to 60 microns is optimal for pain modulation. And we're confirming that now with the EEG. I want to thank my wonderful lab for all this hard work. Some of them are alumni now, and they're doing great things. And of course, our clinical collaborators that have guided us throughout, and our sponsors over the years. Thank you.
Maybe I'll just ask you a couple of things that are kind of big picture questions. I mean, so you've talked a lot about temperature, but I didn't really get the sense that you were really sort of nailing it down to like, this is a temperature effect. Like, what's your thought about the effect? What's the physical effect?
That's a great question. I think definitely the temperature has a role. Um, my thinking is in the nerve, at least, like I showed you, I tried to show anyway, that it could be inhibitory in the nerve because of the, the electrical stimulation suppression that we could see here. It's something that we think that if we have control over, we can go from excitation to inhibition in the nerve. Now, in the brain, I am not sure. I think we're trying to avoid temperature elevation. I mean, I know that 2 degrees C, it's something, I mean, the FDA for imaging, at least, allows up to 1 degree C, and that's considered safe. Of course, we're not, and then it begs the question, people who use very low pressures, obviously, most likely they don't have temperature elevation. But it depends also how long your pulse duration, like you said.
Mm-hmm.
So I think that's what we're trying to do. We're trying to monitor, and I wish us luck here, temperature and displacement during the focused ultrasound modulation. So, but I think that's, until we do that, the jury's still out about exactly how the two potential mechanisms are, are contributing to the modulatory aspects.
Mm-hmm. Yeah, and it's really super to see all your studies that you're starting to do in humans. It's really fun to see.
Yeah, it's actually better than we thought, especially with the pain sensation that we see in some these patients. And we do carpal tunnel now as well. And very preliminarily, it's also suppressed there. So, but it's very, 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 very early to tell. But there's something happening with the focused ultrasound and pain. It's very interesting.